This normally leads to a short-term relief. You feel better afterwards, but then there are long-term negative consequences feeding into these negative thoughts and feelings. So for example, very simple, my boyfriend dumped me, I feel bad, I cut myself, I feel relief, but then I didn't go out, and this led to increase my feelings of feeling bad. Or to give us some other examples, I feel helpless, sad and angry, so I overdose. Others take care of me, but then they handle me with velvet gloves, which makes me feel even more helpless, and I'm stuck in a cycle. And you ask the adolescents, okay, what can you do? You choose, if you can choose an exit, where would you choose that? And for example, I'm not good enough. I hold back my feelings. From time to time I explode, and I cut myself, I feel better. But others think I'm a freak, which leads to me feeling sad I'm not good enough. Or even more here. I'm not lovable, I hold back my feelings, anger builds up, there's no way out. Then I smoke weed, I feel better shortly, but then like a pathetic loser. I cut myself, I feel better shortly, but again like a pathetic loser. I stay at home and refuse to talk to anyone, which creates a feeling of I'm not lovable and not good enough. So thinking about this, where would you see an exit? Because you're all mental health professionals. Is there an exit in this vicious cycle? What could you do? And the adolescent has to choose. Yeah, go on. Go on with ideas.
Before smoking, before getting angry, before cutting himself.
Yeah.
I mean, we can interfere in the emotional dysregulation
Yeah.
part.
Yeah, maybe better ways.
Avoidance part.
Yeah, yeah, you can interfere in this too. Yeah. Other things. You can challenge the thoughts, yeah. Here, yeah, yeah. Sorry?
But I'm not good enough for...
I'm not good enough. Yeah, this is something that you can... The funny thing is you can find an exit everywhere if you work psychotherapeutically. The thing is that they let the adolescent choose which exit they will take. And then they say, okay, until our next appointment, you don't have to do any homeworks. They did it before, but they left it because no adolescent was doing any of their homework, so and it didn't lead to anything getting better. They say, okay, just in the next week, maybe just look out for situations or feelings when this was less a problem and it felt like you were on your way to an exit. And just by changing this perspective and looking more into solution focused, often within the next sessions, people turn up and say, hey, listen, I've experienced some of it got better. So I have some videos that I'm going to skip because the tone is not working anyway. So this could be a diagram, for example. And then descent, and this is a vital part, an understanding letter. So they are finished, the adolescent walks home, and they are writing a letter to them 7 days after. They are describing the diagram, they point out the protective factors that they heard from the history taking, they motivate the adolescent to work further, and they state time and date for the next meeting. And this leads to an increase in those participating in psychotherapy because there's a lot of engagement going on, a lot of things from motivational interviewing, a lot from cognitive analytic therapy, and create some sort of a relationship. Just very quickly to school-based prevention, and that's about it. This is a systematic review about school-based prevention work. There are a lot of RCTs actually in schools, and some non-RCTs, and some also in universities. One thing that has been shown over and over again, that you don't create iatrogenic effects, so people don't get worse. If you talk about suicide in schools or in universities, they all have the elements of psychoeducation, social support, and skills training. In the US, there's the school-based prevention program called Signs of Suicide. This is even a replication sample for that. And they were able to show lower suicide attempts rate over 3 months follow-up, a gain of knowledge, although they didn't find a help-seeking behavior increase. In Europe, there was the large series study, 11,000 participants from 11 Europe countries, and they compared gatekeeper training. This was a randomized controlled trial to youth aware of mental health, meaning 5 sessions, 5 hours in the classroom, where you talk about mental health issues, stress, and what you can do if you have stress. Screening intervention, where they were screened and referred to psychiatry if they were above a certain cutoff, and a minimal intervention, where they just handed out posters and cards. There was one intervention. Which one would you guess? The other ones didn't work for suicide attempt prevention, but which one was the one intervention that worked? Was it training teachers? Was it hanging up posters? Was it screening and sending them off to psychiatry? Or was it the 5 sessions in the classroom?
Again, the question.
What worked? Yeah, the question is what worked. It was the 5 sessions in the classroom. So the 3 of them, gatekeeper screening, minimal intervention, yielded no effects, but by going in the classroom, having 5 sessions there, they halved suicide attempts and suicidal ideation in 12 months follow-up. So it's really an effective measure, has been shown in a randomized controlled trial. So in ending this, just the discussion points, I was able to show you that suicidal thoughts and attempts are frequently found in these age groups, whereas suicide is still rather rare in comparison to adult age. Based on knowledge about risk factors, risk assessment is of course a process of weighing these factors. It's not just knowing them, but understanding what does the risk factor mean for that particular person in that particular situation. And there are treatment options available for suicidal youth. You need to include the family, you need to look into problem solving, communication skills, but they work. And for treatment, the best evidence that we have is psychotherapeutic approaches. They really have a potential to make a difference. That's about it. Thanks for your attention, and if there are any questions, just well, thank you very much. Sorry for the video, but yeah.
You haven't any notices about the cultural differences among about suicidal thoughts or ideations? Is it the fear between a religion to another, an ethnicity to other?
Yeah. Well, in the very beginning, when I talked about the global picture of suicide, pointing to the Nagavi study, there are, of course, nations with high rates of suicidality, like the Baltic states, like Lesotho, Zimbabwe. But we can see pretty much the same pattern everywhere, high rates in old men, with the exception of the mid-Asian room, where we have higher rates in young to middle-aged women. That's the example of China. This is always a paradox in suicide literature. You mentioned religion, which is a protective factor, and it may explain lower rates of suicide, for example, in Egypt when compared to worldwide rates. And it always struck me because I'm used to working with youth who are very secular, so they are not religious in any way, don't believe in anything, religious-wise. But when we saw a lot of refugees and unaccompanied refugee minors from Syria, Afghanistan in 2015-2016, and those were very troubled youth, a lot of traumatic experiences, very hard traumatic experience, and the series of them, and they were clearly feeling awful and desperate. But the one thing that always struck me is that they said they would never, because of course you do your suicide assessment when you see those kids, they would never commit suicide because it's not the will of God. And it always holds true. So you could always send them home if they said that they would not do it. They would have not a single case in which that was not true. We saw some of them who were so desperate they said that I can't stand my life anymore, and I want to, for example, if the family got killed, I want to go to the same place that they are. But still, this was very different from the normal German or Austrian youth that you were working with, in which religion plays no role. Another question, please.
I wanted to ask from your experience, we are talking about the risk factors or the alarm that we say that we are going to, this is a high risk suicidal patient and needs hospitalization. After he is hospitalized, when do you say that it's now safe to send them home? It's always hard to say this, especially in adolescents. Most of them, they want to get home, and they don't like staying at the hospital. They don't think it's safe. safe now to send this
Well, there's never a 100% chance, and then you have to get rid of the thought that anybody of us have a special sense for these cases. You lose that thought when you lose your first patient to suicide. But the thing is that I always want to have a plausible explanation of things that changed. So what was the circumstance then when they were highly suicidal in comparison to now when they are telling me that it's not a problem? So I want to have a plausible explanation for, and things could change. Yeah, they could get away from a boyfriend, a family situation could change, whatever. I would like to have a plausible explanation for that, and I would want to have some sort of a security net. So I would get a feeling that they are okay to talk with their parents about their problems, or that they could use the parents in case they feel worse again, or get worse again. Plus, I would then see them on a very frequent basis at outpatient. And my experience is that normally you can trust them if you have the feeling that really something has changed since they are laughing. It doesn't have to be something that is actually there in their surroundings. It can also be a mindset that changed, or how they perceive a situation. That would be the thing that I would look for. Plus doing, of course, safety planning, seeing that there's a social security net around them, and seeing them again in a very short time. Yeah, go ahead.
I'm wondering about the impact of the social media, especially when you said about the report of the 13 reasons why. Is it with awareness versus the 13 reasons why approach?
I think it's a double-edged sword. And I'm not one among those who say that social media brings out the worst in everybody. And I mean, what can you do? The internet is there and it will not go away. So we have to work with it. And I think that, so we've been even doing some studies on people who were very suicidal and posting things on Instagram. And we contacted them, did a qualitative study for the reason for posting things. And what they told us was that communicating about their suicidality or their self-harming thought was a relief for them, because they found the anonymity of the internet to be a good room to talk to people. So I think it could be a relief as well. So I'm not, but on the other hand, of course, it can be triggering, and we know that social contagion mechanisms are going on, especially with self-injury, but also in suicidality, mentioning 13 reasons why, and people sharing this. So I don't have a clear answer for that. I mean, just that social media is out there. I think the one way you should do, and that's why I was bringing up media assessment, is talk to the adolescent that is sitting in front of you about their social media use, and not just asking, as we did in years way back when we said, have you talked about suicide to anyone, but saying, have you written about it? Have you communicated on social media about suicide? Do you know other people who communicate about social media and suicide? What does it make to you? So I would use that included in my risk assessment.
Do you think concerning the polygenetic risk score and suicide?
There seem to be, I just recently saw a presentation of Dan Rojescu, who is one of the big geneticists, and there seems to be that now, as they are lumping together huge and huge samples, you know, the Manhattan plots, now the Manhattan plots, the first two genes got over significance level, and these were genes that had something to do with serotonin, transmission, serotonin transmission, either on the receptor level or at the presynaptic level. So, it could increase our knowledge, but now it's the first time I ever saw a geneticist saying that, you know, with Chivas, we are finally above significance. Although one has to say it doesn't explain very much of the variance. So it's still below, I think 5%. It's explained by this genetic variance.
What do you think about the role of lithium in preventing suicide?
We have no literature on,
Classical treatment.
we have no literature on adolescents, to be fair. We have one case series by King. We have a lot of literature from adults, so it's an anti-suicidal drug, as well as clozapine. So both of them have anti-suicidal properties. This has been shown over and over again in adult literature. I just didn't mention it because I was not focusing on pharmacology. I'm not using it as an anti-suicidal drug. So what I'm going to do is treat the underlying condition, be it depression, anxiety disorder, what else. And if I need to, then I'm using lithium for bipolar disorder, but not in an anti-suicidal manner. The problem with lithium, from my point of view, is that it has a very short range until it becomes there's an intoxication, and adolescents who are suicidal can intoxicate themselves very easily. So they have, you give them a mean at their disposal, and even an adolescent lifestyle involving sports, not drinking regularly, they can also involuntarily get intoxicated quite fast. So I'm a bit trying to keep my hands off lithium.
Second question.
Yeah.
How would you deal with an adolescent who has a lot of rumination about, if I am performing suicide, I will take revenge from my family and I will let them remorse their relation with me.
Yeah.
How would you deal with it?
Well, the first thing I would do, because I always like to kind of be a bit confrontative if we have a good relationship, I would ask them, well, you're dead then. Well, this wouldn't be actually something that you would get something out of it, because you will never notice, because you're dead by then. And so, well, yes, there's a lot of revenge involved, but how does it help you specifically? Because you're dead.
You will not enjoy it.
You will definitely not enjoy it, because you won't be there to enjoy it. And starting from that, I would of course question whether there are maybe other ways in trying to get what he wants from the family, and maybe dissolve if there seems to be underlying problems, or there seems to be some fight going on between family members. These things other than suicide, because there's always, and I would say, well, suicide is always a last straw, a last chance. It never goes away. It's the ultimate thing that everybody can do to themselves. But if I have a final decision to make, and I have an alternative that may works as well, then I'm not going for the final decision, because this is just straight dumb. That's what I would tell him. And I would see how he responds to that, of course. But I would make this point very clear, that there might be suicidal fantasies about how they will stand at the grave, and they will say, well, we were all wrong, he was such a good boy, how could we do that? But you're not there experiencing this. And this is something that a lot of adolescents have in their mind, that somehow they will get a gain out of it, but they won't. And you have to be very clear that we're talking about death here.
Children under age 7, they understand the reversibility of the process or not, because
It was a 10 actually.
I have worked with children in the burn unit, 6 years old, and they claim that he performed suicides. Maybe he has seen this TV, but they don't understand the reversibility of the process. I mean,
yeah, there's some literature normally say that it's by age of 10, and it could be that it's culturally different, but what I know from the literature says by age of 10 they understand the death concept, the non-reversibility, the universality, everybody has to die, and all of the stuff that goes along with that. And we don't see, at least in mid-Europe, we don't see a single case of suicide. Haven't seen a single case of suicide below the age of 10 in the last 5 years. Not a single one in all Middle European countries. It might be that we missed out on these cases because they were falsely classified as injury or something like that. But still, I would say, I happen to see 8-year-olds one who say that I would like to commit suicide. What you often find in that cases is that they are copying behavior that they've seen somewhere else, and they found to get some sort of reinforcement for that. So people get worried, they can get what they want, But so those are mostly the things I said. And of course, things can happen. So that then they go a step further and do something, whereas I don't know if they really intended to die or not, but as a matter of fact, I mean, it's now at the burn unit, so I would actually clearly ask him whether he wanted to die or whether that wasn't the case. Yeah.
When I saw him, he denied. No, I don't want. I didn't do this.
Well, it could be that he wanted to have something out of it, and then things got out of control, and he didn't happen. So they went to the burn unit. Yeah.
In the research you presented for the Columbia suicide suicide scale, suicide severity scale, was it a control group? If this scale was done on a control group parallel to the suiciding group?
They were not using a control group if you mean healthy controls, they were actually looking into adolescents or adults who've been psychiatric patients and who had a history of suicide attempts. Yeah.
They presented with a suicide.
Yeah, because why did they do so? The thing is that they wanted to have a group with an elevated risk. Because if you only have a 6 months follow-up, you would like to look into a group with an elevated risk, because otherwise you will need a very large proportions. Yeah. But these were all persons with a history. Oh, was it?
In the beginning, yes, this one.
Yeah, there it was. Yeah. So these were adolescent suicide attempters. That was the very first study by Kelly Klosner, and for this prospective study, this was a psychiatric cohort. So this was taken for psychiatry, regardless of their suicide history.
Right.
All right, and thanks for staying so long. Thank you very much.